So I think, in the main, with diffuse large B-cell lymphoma, we are doing very well in terms of the success of first-line therapies. So with conventional R-CHOP chemotherapy, we would expect maybe 80% of people to have a good response, and for very many of those to be cured by first-line therapy. But for the numbers of patients that either fail to respond to R-CHOP chemotherapy initially or relapse after having had chemotherapy, then the treatment is much more difficult. And this study that we were doing was looking at patients who had relapsed or refractory diffuse large B-cell lymphoma who were not eligible for the conventional second-line chemotherapy and transplant strategy, or had relapsed after having had that. So a group of patients that either were not fit enough for it or had relapsed after having had second-line therapy with an autologous transplant. And we were looking at lenalidomide, which is an immunomodulatory agent, which has a number of mechanisms of action in lymphoma, and was given as an oral agent every 3 weeks out of 4 until patients progressed. And we were comparing lenalidomide, which had shown some activity in some of the earlier studies, to investigator choice treatment. So that could be a single agent gemcitabine, rituximab, oxaliplatin, etc. And what we demonstrated in this study was actually that the response rates were much higher in the lenalidomide treated group of patients than in those patients who were treated with the investigator choice chemotherapy, and that the time to event endpoints were also longer. And what was really interesting was we did a analysis of the cell of origin of diffuse large B-cell lymphoma in this patient population, and we saw that patients who had the activated B-cell phenotype of DLBCL responded much better than those patients who had the germinal center B-cell type phenotype. So actually what we're seeing is a potential selection of therapy both based upon our knowledge of the biology of the disease rather than just one single fit for all. So I think this is a really interesting study. The toxicity profile was very good, and this looks at about 100 patients. So what we see is that the response rate for lenalidomide was much better than the investigator choice treatments, and those better response rates translated into better time to event endpoints such as progression-free survival. There were interestingly patients who had the chemotherapy were able to cross over to lenalidomide at the time of progression. So there's an interaction in some of these time to event points, but actually we saw responses in people who had failed with the standard investigator choice treatment. In terms of the take-home message, it shows that lenalidomide provides a useful potential palliative option as a single agent in patients with relapsed or refractory DLBCL who aren't eligible for a transplant strategy. So that's useful. I think the other thing is that a key thing about this is about selection of therapies based upon the biology of the disease. And I think that we're increasingly going to see this with the different novel agents that we're looking at in DLBCL and other forms of lymphoma, that actually by understanding the individual patient's biology, then we'll be able to try and target therapies much better for the individual. So I think that's a really important take-home message. And the other thing to say is actually we're looking now in studies of lenalidomide not just as a single agent, but in combination with other chemotherapy drugs in diffuse large B-cell lymphoma. And it kind of these response rates stands as a great backbone for looking at this either in addition to CHOP chemotherapy in the frontline setting or in strategies for relapsed disease in combination with chemotherapy.